Hi, this is Dr. Samson Chan. Today I'm going to give you a great clinical tip. 95% of the time, your inferior alveolar nerve block that you learn at dental school work 95% of the time, maybe even 98% of the time. However, there are a few that didn't work. Why? Because of anatomical variation. As the inferior alveolar nerve enters the ramus of the mandible, the position of the lingula, the mandibular foramen can vary. What other technique you can use? There are at least two major techniques. The two major ones is the Gow Gate technique and the closed mouth achinosis technique. Today we're going to look in detail how to perform the Gow Gate technique. In 1973, an Australian dentist described a new approach to mandibular anesthesia. With his technique, he really aimed at the neck of the condyle instead of the lingula of the mandible. The neck of the condyle is in close proximity of the mandibular branch of the trigeminal nerve as it exits the skull. The patient's mouth needs to be wide open because when the mouth is wide open, the condyle will slide forward and downward onto the articular eminence, exposing the neck of the condyle. This is a perfect opportunity for us to deposit at the neck of the condyle, where the trigeminal mandibular branch of the trigeminal nerve lies. So you penetrate hip bone from the contralateral side in between the lower bicuspid. Aim high, really you're aiming at your finger. Actually, the index finger you will have to place on the intratracheal notch. That is in proximity to the condyle. So there you go. This is the bony landmark. Next, let's look at the soft tissue landmark. Okay, now let's look at your standard armamentarium to perform such a procedure. First, you have your good old-fashioned Silent King topical ointment, and then you're gonna need a long cotton stick, the good old-fashioned Vaseline because the patient lips need to be wide opened because your finger will be in the way, will be pressing on the corner of the mouth, and then a mouth pop, and then finally your good old-fashioned 27 gauge long needle with the aspirational function. First, external landmark. This is the condyle. So you inject from here. You're aiming almost as if you want to cut through your finger. The point is the soft tissue next to the lingual cusp of the second molar. Like this. This is the correct angle. This is the condyle, the tragus of the ear. This one, the commercial of the mouth, directly to the tragus of the ear. And then you inject from the canine, in between the canine and lateral incisor. Directly aiming to the second lingual cusp measure, and then here is the penetration point. This is the mandibular plane angle. This is the tragus. You're aiming the condyle. This is the direction of the injection because this is where the condyle is. And then we inject directly below the condylar head. In theory, the thumb, you palpate the coronoid notch of the mandible. So you secure in place and then you inject into this area like that. Okay. So now we're gonna demonstrate. So you're gonna need a 27 gauge needle. You're gonna have to empty the whole carpule in between the cuspid and bicuspid at that angle. Okay, now you hit bone. You withdraw a little bit, aspirate, and then you give rest of the solution slowly. Slowly. Okay. Slowly, slowly. Slowly, slowly. Slowly, slowly. Slowly, slowly. After you hit bone. And then this is the Gow Gate technique. we inject the whole 2 mil. Mouth port like this. To put in the mouth for 1 or 2 minutes after injection, so the injection disperses everywhere. So now it's after 2 minutes. So it should numb the mental nerve, the inferior border of mandible, the origotemporal nerve, maybe sometimes the buccal nerve as well, and then the mylohyoid nerve, and sometimes the non-buccal nerve. So that's it. This is the Gow Gate technique. Thank you for staying tuned. Thank you so much.